Kanski lecture series, and this is going to be the chapter 11 glaucoma part 8, and in this part we are going to discuss about the secondary glaucoma. So secondary glaucoma is basically that glaucoma in which there is a ocular or non systemic factors which is causing the raised IOB. Now these can cause the open angle glaucoma, and this can be closed angle. So, secondary open angle glaucoma can be subdivided on the basis of the site of the aqueous outflow obstruction. Pretrabecular, in which the aqueous outflow is obstructed by the membrane covering the trabeculum, which may consist of. So, in case of open angle secondary glaucoma, basically the angle is open, but there is a membrane that has been formed which is obstructing the flow from the uh, anterior chamber to the trabecular meshwork. So it contains the fibrovascular tissue, like in the neovascular glaucoma. One thing is that neovascular glaucoma can cause both open angle and closed angle as well. So fibrovascular tissue, endothelial cell, membrane cell proliferation, iridocorneal endothelial syndrome. This is also a membrane that formed over the trabeculum. Epithelial cellular membrane proliferation, epithelial ingrowth. Now next is the trabecular. Trabecular, in which the obstruction occur as a result of a clogging up of the meshwork and the secondary degenerative changes. For example, pigmentary, basically angle is open, but there are certain things that are particles that are obstructing the trabecular meshwork, like a pigment particle which is causing the pigmentary glaucoma, red blood cell and which is causing the red cell glaucoma. So then there is a degenerate red cells which cause the ghost cell glaucoma. We will discuss the ghost cell glaucoma in the coming lectures. Macrophage and the lens protein which causes the phacolytic glaucoma. Protein, probably an element in an hypertensive uveitis. Pseudo exfoliative, so basically this is those with a uveitis having a glaucoma, is basically the proteins that are clogging up the trabecular meshwork. Pseudo exfoliative material, pseudo exfoliative glaucoma. Trabecular glaucoma may also be caused by the alteration of the trabecular fiber themselves by edema. For example, trabeculitis in hypertensive uveitis, or scarring post-traumatic angle recession. Post-trabeculum, in which the trabeculum itself is normal but the aqueous flow is impaired as a result of the elevated episcleral venous pressure. Very important: keratoid cavernous fistula, Sturge-Weber syndrome, obstruction of the superior vena cava. These are all causing the elevated episcleral venous pressure that is causing the outflow obstruction. Then there is a closed angle. Then there is a with pupillary block and without pupillary block, in which basically the pupillary block means that the pupil has become blocked and it is not letting the posterior chamber aqueous humor to outflow to the anterior chamber. Number one is occlusio pupillae, 360-degree posterior synecdoche, usually secondary to recurrent iridocyclitis. Subluxated lens, phacomorphic, so these are all causing the obstruction of the pupil. Phacomorphic glaucoma, capsular block syndrome with 360-degree iris capsule adhesion in a pseudophakic eye. So we will all discuss it in the coming lectures. Pupillary block, anterior chamber lens implant without a patent iridotomy. Without pupillary block, secondary causes of the past such as advanced neovascular glaucoma and chronic anterior uveitis. Basically, the membrane that has been formed are contracting and causing the peripheral anterior synecdoche, in which is causing the obstruction of the outflow. Ciliocoroidal effusion, capsular block syndrome without iris capsule adhesion. Ciliary body or iris cyst or other ciliary body or posterior segment tumor, contraction of the retrolenticular fibrovascular tissue such as in proliferative vitreoretinopathy and retinopathy of prematurity, malignant glaucoma, ciliolenticular block. So you can see this figure. This is a pathogenesis of the secondary glaucoma. A is showing the pretrabecular obstruction. There is a membrane that has been formed. B is trabeculum obstruction, and C is basically angle closure with pupillary block. You know that pupil has been blocked and it is not allowing the flow from the posterior to the anterior chamber. And D is showing the angle closure without pupillary block. So next is the pseudo exfoliation. So very important topic. It is a very commonly encountered. Basically, there is a difference between pseudo exfoliation and the pseudo exfoliation glaucoma we will study. So, introduction: pseudo exfoliation syndrome (PXS) is an important ocular manifestation of a systemic disorder and is the commonest cause of the secondary open angle glaucoma. So, this causes an open angle. It is easily overlooked in early stages as the signs are not always obvious. It is rare before the age of 50 years. But the prevalence increases rapidly after the sixth decade of life, with prevalence of 5% at 75 to 85 years. So basically, the prevalence is 5% at 75 to 85 years. It is more common in women than in men, although the condition is found worldwide and the prevalence is highest in the Scandinavia. Not all patients with a pseudo exfoliation syndrome will develop glaucoma, and there is no reliable method of determining which patient the condition will subsequently develop optic disc damage. The incidence of the glaucoma, pseudo exfoliation glaucoma at diagnosis of PXS is 15 to 30%. And cumulative risk of eyes with the pseudo exfoliation syndrome requiring glaucoma treatment may be as high as 60% at 5 years. It should be distinguished from the true capsular exfoliation, which occurs secondary to the chronic infrared exposure, glass blower cataract. So, what is a true exfoliation and a pseudo exfoliation? Basically, the true exfoliation that occur after the infrared exposure and this is called the true exfoliation. But the pseudo exfoliation is basically an extracellular fibrillin material that has been deposited in the various part of the body and in the eyes as well. So it is basically age related, and it is more common after the sixth decade of life, and mostly it has a prevalence of 5% at 75 to 85 years. So most of the cases, if we diagnose a pseudo exfoliation syndrome, 15 to 30% will have glaucoma at the diagnosis, and pseudo exfoliation syndrome requiring glaucoma treatment becomes 60% at 5 years. Pseudo exfoliation glaucoma progresses more rapidly than primary open angle glaucoma and may likely to result in a significant visual loss. So it is more damaging glaucoma than a open angle glaucoma. So what is the pathogenesis? So pseudo exfoliative material is a gray white fibrillary substances deriving from an abnormal extracellular matrix metabolism in ocular and other tissue. So basically it is a fibrillin material which is due to the abnormal extracellular matrix metabolism. The material is deposited on various ocular structures, including the lens capsule, zonular fibers, iris, trabeculum, and conjunctiva. So basically, it is on the so these type of material deposited in various part of the body. It can deposit on the lens capsule. It can deposit on the zonules that are hanging the lens, and it can also deposit on iris, trabeculum, and conjunctiva. Pseudo-exfoliative material has been found in the skin and the visceral organ, leading to the concept that pseudo-exfoliation syndrome is an ocular manifestation of a systemic disorder. So basically, it can be found in other parts of the body as well. Pseudo-exfoliation syndrome is associated with an increased prevalence of the high-tone hearing loss and a cardiovascular disorders. So that is why basically it is an age-related. So hearing loss can also occur in this patient. The pathogenesis is multifactorial, but in some population, almost all the patients with the pseudo-exfoliation syndrome have a single nucleotide polymorphism in the LOXL1 gene on chromosome 15, which codes for an enzyme that is involved in a cross-linking of the tropoelastin and collagen, and is then therefore important for the formation and maintenance of the elastic fiber and an extracellular matrix. So basically, LOXL1 gene is basically linked to the pseudo exfoliation syndrome as well. So what is the role of LOXL1 gene? It is basically codes for an enzyme which cross-link the tropoelastin and collagen, and it is important in the formation and maintenance of the extracellular elastic fiber and extracellular matrix. However, these SNPs are common in the general population, and most individuals with SNPs do not develop pseudo exfoliation. So it can also be found in the normal people as well. Plasma and aqueous humor homocysteine levels tend to be higher than controls than an inadequate dietary folate intake. Folate reduces homocysteine may be risk factor. So basically the homocysteine level can also be increased in these cases, and that an inadequate dietary folate intakes can also be the risk factor. Open angle glaucoma, sometimes capsular glaucoma, is usually due to elevated IOP secondary to the trabecular obstruction by the pseudoexfoliative material and liberated iris pigment, leading to secondary degenerative outflow dysfunction. So what is the mechanism of the glaucoma? Basically the trabecular meshwork is being obstructed by the pseudoexfoliation material, and also the iris pigment that has been liberated, and it also caused the outflow dysfunction. Curiously, despite the systemic nature of the condition and the fact that biopsy reveals subclinical pseudoexfoliative material in the apparently unaffected eye, glaucoma remains confined to one eye in about two-thirds of the patients. So it is usually unilateral glaucoma, despite the condition tends to be bilateral. Diagnosis is usually incidental. Clinical features. Diagnosis is usually incidental but can follow visual loss from advanced glaucoma. So there are certain changes from the cornea that can happen, anterior chamber, iris, lens, and anterior chamber angle, IOP prognosis. So cornea pseudoexfoliative material may be deposited on the endothelial, and scattered pigment deposits are common. A vertical Krukenberg spindle may rarely form, similar to that seen in the pigment dispersion syndrome. Endothelial cell abnormality such as lower density is more common than average. So basically in the corneal changes, basically there will be the pseudo exfoliative deposition on the endothelium, and there can be the scattered pigment deposition as well. The Krukenberg, which is a characteristic sign of the pigment dispersion syndrome, can also be present in a pseudo exfoliation syndrome. And endothelial cell counts are usually low. Anterior chamber pseudoexfoliative material particles are sometimes seen. Mild aqueous flare from an impaired blood aqueous barrier is common. So in this case there will be the impaired blood aqueous barrier and there will be the aqueous flare. So what will be the changes in iris? Granular pseudoexfoliative material deposit, pupillary rough loss, and a patchy transillumination defect at the pupillary margin. So very characteristic, the iris have a pupillary pseudo exfoliative material deposition at the pupillary margin most likely, and there is a pupillary rough loss, and there can be the patchy transillumination defect. So we can see figure 11.4 to a. So we can see that there is a pseudo exfoliation material at the pupillary margin and there is a loss of pupillary rough. Then there is a lens. The interior lens capsule typically shows a central disc and a radially indented peripheral layer of the pseudoexfoliative material separated by the clear zone maintained by a pupillary abrasion. Peripheral capsular deposition is only visible with the pupillary dilatation. Deposit may be flaky with scrolled edges. Cataract is more common in eyes with pseudoexfoliative material, probably because of the reduced ascorbate level in the aqueous. Phacogenesis, lens instability due to zonular weakness may be present, but spontaneous subluxation is rare. So basically in a case of a pseudo exfoliation, you can see the pseudo exfoliation material in a two forms. So this is a lens. You will see the material at here and then you will see here. Between them is a clear zone. Why? Because when the pupil move from meiosis to dilatation, it will cause the abrasion of the pseudo exfoliative material. So that is why there is no clear zone between them. So this peripheral pseudo exfoliation material will only be seen in the case of the pupillary dilatation. And also that there can be lens instability because of the zonule also have a deposition of the pseudo exfoliative material. Anterior chamber angle very important, because we will see here that there is a risk of angle closure in the pseudo exfoliation as well. However, it is referred to as a open angle, secondary open angle glaucoma. Patchy trabecular and Schwalbe line hyperpigmentation is common, especially inferiorly. A sample SC line, which is an irregular band of the pigment running on or interior to the Schwalbe line, is commonly seen. It is not pathognomic and can be found in a pigment dispersion syndrome. So Schwalbe line, because of the iris degeneration, there will be the Sampolisi line, which is basically the pigmented line interior to the Schwalbe's line. Dandruff-like pseudo-exfoliation deposit material may be seen. There is an increased risk of angle closure, probably because of the zonular laxity. So angle close because of the zonules are becoming lax. So we can see figure 11.4 to so A is showing us the loss of pupillary rough and pseudo-exfoliative material on the pupillary margin. B is showing peripheral pseudo-exfoliative material on the lens, more obvious with the pupil dilatation. C is showing us a retroillumination. D is showing gonioscope, showing a patchy trabecular hyperpigmentation and markedly irregular Sampolisi line. So you can see there is a Sampolisi line which is anterior to the Schwalbe line. So how is IOP? In most cases, the presence of the glaucomatous damage is associated with elevated IOP. The majority of the patients have a chronic open-angle glaucoma that is unilateral at first. Occasionally, IOP may rise acutely despite a wide angle mimicking acute angle closure. This is worse than POG, as the IOP is usually higher and may exhibit marked fluctuation. Severe damage may be present at the diagnosis and can develop rapidly. So it is more severe because it is more damaging than POG. It advances more rapidly. So that is why its prognosis is worst. In the long term, these patients are at a significant risk of a visual loss and blindness. It is therefore important to monitor patient closely, and it may be prudent to review in patient with a pseudo-exfoliation syndrome to take place at interval of no more than 6 months. So you have to review this patient after 6 months. So how will you treat the patient of the pseudo-exfoliation glaucoma? So there is a treatment. Medical treatment is similar to that of the POG, but failure is common. Laser trabeculoplasty is more effective than POG, with mean IOP reduction around 30%. So laser is also used, in which the trabeculum is being changed so that there is an increased outflow, and reduction is almost 30% following SLT. Care should be taken not to apply excessive energy at trabecular meshwork. Trabecular pigmentation may confer higher absorption, resulting in transient IOP spike. A significant rise in IOP may occur approximately 2 years after SLT. So SLT become failed after some times. Phacoemulsification alone may significantly lower IOP because the cataract is common, and cataract extraction lowers IOP. So it may give better control combined with trabeculotomy, lectomy. There is a high risk of complication due to poor matrices, increased fragility of the zonules, and the lens capsule and endothelial deficiency. So there are certain problems that you encountered during a cataract surgery of a pseudo exfoliation. Basically, it has a case of a zonular weakness. There will be the poor dilatation, and there will be the endothelial deficiency as well. There is also an increased risk of a post-operative IOP spike, post-operative corneal edema, inflammation, capsular opacification, capsular axis contraction, capsular phimosis, and late IOL decentration or dislocation. Filtration surgery in pseudoexfoliation glaucoma has a similar success rate to POC. Trabecular aspiration alone seems to confer at least a short-term benefit and can be performed at the same time as the other intraocular procedures. Pigment dispersion syndrome and pigmentary glaucoma. Pigment dispersion syndrome is characterized by the liberation of the pigment granules from the iris pigment epithelium and their deposition through the anterior segment. So basically, pigment dispersion syndrome is basically a disease in which the pigments are being liberated from the iris, and these iris pigment then attaches to the other parts of the ocular surface like endothelium, trabecular meshwork. So that's it. So, secondary pigmentary glaucoma is common. Pigmentary dispersion syndrome and pigmentary glaucoma are common in males. So, these are more common in males, particularly young myopic white men, and it is more common in myopic patients. So, pseudo exfoliation presented in late older patients, and this is in the younger patient. In Africans, where it is rare, the condition tends to affect the older hypermetropic women. So, in Africans, it affected the opposite to that which is usually present. It is present in older hypermetropic women. About 15% of the patient with the pigment dispersion syndrome will develop elevated IOP or glaucoma after 15 years. So it will have if a patient is diagnosed with the pigment dispersion syndrome, it will have 15% of them will develop glaucoma after 15 years. Autosomal dominant inheritance with incomplete penetrance seems to be present in at least some families, and a range of genetic loci have been linked. So, it is basically a genetic association as well. Myopia is a risk factor for clinical manifestation. High degrees of myopia being associated with earlier and more severe glaucoma. Secondary pigment dispersion can occur as a consequence of trauma, intraocular tumors, and rubbing of a malpositioned IOL on the iris pigment epithelium. So, what is the pathogenesis of a pigment dispersion syndrome? So, what is the pathogenesis of the pigment dispersion glaucoma? In primary pigment dispersion syndrome, pigmentary glaucoma, pigment shedding is precipitated by rubbing of the posterior pigment layer of the iris against the zonule as a result of the excessive posterior bowing of the mid peripheral portion of the iris. So, what is happening is basically, that iris is basically rubbing against the zonules. So, these rubbing of the iris against the zonule will cause the liberation of the pigments. It is believed that increase in the anterior chamber pressure relative to the posterior chamber occur due to reverse pupillary block, uh, supported by the observation that uh, a peripheral iridotomy flattens the iris and decrease iridozonular contact. So, basically, what is happening in this case, the anterior chamber is having a more pressure, positive pressure, than a posterior chamber. So what is happening, the aqueous start flowing from the anterior to the posterior chamber and causing the reverse pupillary block, and the pupil is getting blocked. The pigment epithelium itself may be abnormally susceptible to shedding in effective in visual. Pigment shedding decreases from the middle age onward due to physiological changes resulting in a decreased iridozonular contact. So with age, it is getting better. Acute IOP elevation can occur due to direct trabecular obstruction by released melanin granules. So, how the trabecular meshwork are getting obstructed? By the melanin granules. Chronic elevation appear to be caused by the pigmentary obstruction of the intertrabecular space and damage to the trabeculum secondary to denudation, collapse, and sclerosis. Patients with pigmentary glaucoma have an increased incidence of the steroid responsiveness. So, those who with the pigmentary syndrome using steroid have a increased risk of getting the steroid responder induced glaucoma. Next is, how will you diagnose the case of a pigment dispersion syndrome presentation? Pigment dispersion syndrome and pigmentary glaucoma are typically detected at a routine eye examination. The myopic individual who tends to develop the condition are likely to be under regular optometric review. Occasionally, symptoms from the glaucomatous visual loss lead to attendance or from the corneal edema due to acute IOP rise following the release of the pigment granules. So, basically, the patient does not present to you. So, the myopic patient who are basically under observation are getting diagnosed. But the patients present with the glaucomatous visual field loss that occur, or from the corneal edema which occur due to acute IOP rise, presents to us in the OPD. Following the release of the pigment granules, particularly after physical exercise, signs of the PDS are usually bilateral but may be subtle and go undetected. So, this is usually a bilateral condition, whereas pseudo exfoliation with even bilateral condition have present as a unilateral glaucoma. Cornea pigment is deposited on the endothelium in a vertical spindle shaped Krukenberg spindle. The spindle is not always present, named to become less obvious in a long standing cases, and it is not pathognomic. So basically, the pigment become a line shape, vertical line shape on the cornea, which is called the Krukenberg spindle. Let's see figure 11.44. So A is showing us the Krukenberg spindle. So there is a vertical line of the pigment depositions on the endothelium. And this figure is showing ultrabiomicroscopy in a pigment dispersion syndrome. A is showing deep anterior chamber and posterior bowing of the peripheral iris. B is showing the flattening of the iris following laser iridotomy. Anterior chamber is deep and melanin granule may be seen in the aqueous. So in this case, this is also an open angle glaucoma. Iris characteristic radial spoke-like transillumination defects are seen in lighter but often not in dark iris. To best demonstrate this, the room should be minimally illuminated and a short, narrow but intense slit beams directed through the pupil. Visualization may be aided by asking the patient to look up. Melanin granule may be present on the inferior surface of the iris, on the surface of the iris, usually inferiorly, which become less obvious with age. There may be partial loss of the pupillary rough. So basically, when you do the trans elimination, retro elimination, you will see the defects in the mid periphery of the iris, and there is also the loss of the pupillary rough. So B is showing the radial spoke like iris transillumination defect. C is showing a pigment granule on the iris surface and inferior loss of the pupillary rough. D is showing a homogeneous band of trabecular hyperpigmentation. So trabecular meshwork become hyperpigmented with age. So what is the gonioscopy? The angle is wide open and there is often a characteristic mid-peripheral iris concavity where the iris bows backward. So iris is basically a little bit of concave and the iris posterior bowing of iris. The trabecular meshwork is heavily pigmented in all the pore quadrants. So trabecular meshwork is pigmented with a dense homogeneous circumferential posterior meshwork band. Pigment may also be seen on or interior to the Schwalbe line, which is known as Sampolisi line. Pigmentation of the angle typically reduces with increasing age. Lens. Pigment granule may be deposited on the interior surface. There may be line, sky strip or Zentmeyer ring of a pigment on a peripheral equatorial surface around the zonular insertion. So basically this is the pigment can also deposit on a lens. So when it is deposited on the equatorial surface, this is known as a Zentmeyer, whereas when it is deposited on the as a line, this is known as sky strip. IOP. This may be volatile. Some patients exhibiting higher level and wider fluctuation of IOP than POC. Over time, the control of IOP may be easier as pigment liberation decreases, and occasionally the IOP may report to normal. So with age, the IOP tends to decrease. Normal tension glaucoma can erroneously be diagnosed if the IOP has normalized spontaneously and the pigment dispersion syndrome sign resolved. Posterior segment, peripheral retinal pigmentation may be seen, and lattice degeneration is more common than in myopic patient without pigment dispersion syndrome or pigmentary glaucoma. So basically, it is present in a case of a pigment glaucoma. These are more common. There is more lattice degeneration and peripheral iris pigmentation than those with myopia who do not have a pigment dispersion syndrome or pigmentary glaucoma. The incidence of the retinal detachment may also be higher. Glaucomatous optic neuropathy is depending on the disease stage and extent and may be markedly asymmetrical. It is common to find advanced disease in one eye and relative mild damage in the other. So what will be the treatment of pigment dispersion syndrome? Individual with the PDS should be reviewed annually to exclude the development of raised IOP or glaucomatous damage. So annual review is being recommended. If glaucomatous atrophy is present, the patient should be monitored at 4 to 6 monthly interval, as the combination of myopia and pigment dispersion syndrome can result in rapid deterioration of a visual function. So who are diagnosed with the pigment dispersion glaucoma, they are usually reviewed at 4 to 6 months. So what are the lifestyle measures that has been advised? Excessive exercising can be associated with increased iris pigment dispersion with acute symptoms in some cases. If the history confirms this, appropriate advice should be given to alter exercise behavior. Medical treatment is similar to that of a POC. Myotics are theoretically of benefit because they decrease iridozonular contact in addition to the facilitating aqueous outflow, but are poorly tolerated by younger patients. This medication has a disadvantage of exacerbating myopia and also carries a risk of precipitating retinal detachment in short-sighted eyes. Topical thymoxamine, a selective alpha adrenergic antagonist, induces myopsy without causing spasm of accommodation, but is poorly tolerated as it causes irritation. So basically, they are being prescribed with the same medication as both, and myotics are sometimes being theoretically benefit because they decreases the iridozonular contact, but in patient of myopia, this tends to exacerbate the myopia, and there is a risk of precipitating retinal detachment in the short-sighted eyes. So, topical thymoxamine is an selective alpha adrenergic antagonist that has been used, which causes myopsy without causing the spasm of accommodation, but it is also poorly tolerated. Next is a laser trabeculoplasty is often effective. It is important not to overtreat eyes with heavily pigmented angles. To reduce the risk of IOP spike, use the lower laser setting and treat only two quadrants. So we use only lowest laser setting and two quadrants, because if trabeculoplasty can liberate so many pigments that it will cause acutely elevated IOP. Laser iridotomy has been proposed to retard pigment liberation by reversing iris concavity and eliminating iridozonular contract. This it can reduce the risk of intermittent IOP spike, especially in a patient under the age of 40 years. So, laser iridotomy has also been convincing treatment regime, but it does not reduce the risk of developing glaucoma. Filtration surgery is indicated more commonly than in PO. The use of adjunct anti-metabolite improves surgical outcome, particularly in younger patients on whom there is a risk of failure. Post-surgical hypotony and suprachoroidal hemorrhage are more common in young patients with myopia. Acute bilateral iris pigment loss with raised IOP. Bilateral acute depigmentation of the iris, BADI, and bilateral acute transillumination have recently proposed as a distinct idiopathic clinical syndrome having a pigment dispersal from the iris into the anterior chamber. So basically these are having the bilateral liberation of the iris pigment from the iris into the anterior chamber. They are said to be more common in young to middle-aged women. So they are more common in women occurring spontaneously or following a flu-like illness, possibly after oral antibiotic treatment, especially moxifloxacin. So these are basically stress induced. It is possible that a primary process is inflammation, but there is evidence that a mechanism is phototoxicity following sensitization in a predisposed individual. Presentation is usually with bilateral ocular redness and photophobia. Both may be associated with IOP, right, but this has been reported to be more severe and resistant in BAID. Finding described in the two differ in that pigment is lost from the iris stroma in body and iris pigment epithelium in BAID, with the marked transillumination defect and irregular mydriasis in the latter. So basically the difference between the two is that in a case of a body and there is a BAID, so there is a pigment liberation from the iris stroma in the body, whereas in the epithelium, iris pigment epithelium in the BAID, and there is a marked transillumination defect and irregular mydriasis in this later BAID. It is possible that party and BAID represent different points as on a common disease spectrum. Differential diagnosis is principally from the viral anterior uveitis and pigment dispersion syndrome. So that's it for the glaucoma part 8. See you in the next lecture series.